Good afternoon. I'm a fourth-year resident at UC Davis. Thank you for the opportunity to present today and for being here this afternoon. Oh, there it is. Sorry, guys, I missed the clicker. I tried. All authors have no disclosures. Bariatric surgery is the most effective treatment for obesity and improves or resolves related comorbid conditions. As a result, cases performed annually over the US have steadily increased over the last decade. While many patients report improvement in common gastrointestinal symptoms associated with obesity, including GERD, nausea, bloating, flatulence, diarrhea, and abdominal pain, a subset of patients may develop significant GI symptoms after surgery that affect their quality of life. The prevalence of GI symptoms after bariatric surgery varies in the literature from 0 to 46% of patients, but current data suggests that symptoms are more common after biliopancreatic diversion with duodenal switch or a Roux-en-Y gastric bypass when compared to sleeve gastrectomy or adjustable gastric banding. Diagnosis of reversible causes of these symptoms can be difficult since symptoms are vague and they overlap with many etiologies, including maladaptive eating habits after surgery, but the differential includes exocrine pancreatic insufficiency, small intestinal bacterial overgrowth, bile acid malabsorption, infections like Clostridium difficile, and inflammatory bowel disease. Exocrine pancreatic insufficiency results from abnormal pancreatic enzyme secretion or function and can occur as a primary or secondary disorder. This dysfunction leads to malabsorption, maldigestion, and vitamin deficiencies. While epi is a known complication of gastric and pancreatic resections, it's only recently been identified as a potential cause for GI symptoms after bariatric surgery. To date, only a few studies have attempted to identify risk factors that may predict the presence of epi after bariatric surgery. The goal of this study was to evaluate epi as a cause of gastrointestinal symptoms after bariatric surgery, identify factors contributing to and symptoms predictive of epi diagnosis, evaluate treatment outcomes, and evaluate the overlap of epi with other GI diagnoses. We performed a retrospective chart review at our single academic institution in all bariatric patients from 2002 to 2020. Patients were included if their medical charts contained ICD codes indicating previous bariatric surgery, who were also either diagnosed with epi, had undergone fecal elastase or fecal fat testing, or underwent treatment with pancreatic enzymes. Epi is commonly diagnosed by a low fecal elastase result, but fecal elastase testing is known to underdiagnose those with mild to moderate disease, especially in post-surgical patients. Therefore, we defined positive diagnosis of epi as decreased fecal elastase or improvement of symptoms with pancreatic enzyme replacement therapy. This is a little trigger happy. In total, we found 262 patients who were suspected of having epi. 73 did not complete a workup, while 191 patients were evaluated for epi. Most of those patients got fecal elastase testing, while 10% of them got empiric pancreatic enzyme replacement. Most patients had a history of a Roux-en-Y gastric bypass, followed by sleeve gastrectomy, adjustable gastric band, biliopancreatic diversion with duodenal switch, and one jejunal ileal bypass patient. Looking at our demographics overall, the average age was 57 years, with an average BMI of 33. The majority of our patients were women and of white race. We then examined demographic data based on epi diagnosis. Patients diagnosed with epi were significantly older and had a lower BMI, but there was no difference in gender or race distributions. Of the 191 patients who completed their workup, nearly 42% were diagnosed with epi, most of those by fecal elastase testing and a small portion by empiric therapy. Of the 80 that were diagnosed, 69 had a gastric bypass, some had duodenal switch or sleeve gastrectomy, and none had adjustable gastric banding. Importantly, 48% of gastric bypass patients were diagnosed with epi, and 70% of biliopancreatic diversion and duodenal switch were diagnosed. These two rates were significantly greater than the sleeve gastrectomy group at 17.4%. Therapeutic pancreatic enzyme replacement therapy was given to 66 of the 80 patients who were diagnosed with epi, and 86% of those patients had improvement with symptoms after treatment. We then looked at whether certain comorbid conditions or symptoms were associated with epi diagnosis. And while GERD was the most common comorbid condition in patients evaluated, only chronic pancreatitis was significantly associated with epi diagnosis. This is a confounding diagnosis and therefore an expected association. We also, of the symptoms that we examined that prompted testing for epi, diarrhea was the most common, but no symptoms were significantly associated with diagnosis there. Because symptoms of epi overlap with other diagnoses, many patients were also evaluated for small intestinal bacterial overgrowth via hydrogen breath testing. 40% of patients who underwent workup for epi were diagnosed with SIBO, and similar percentage got antibiotics. Only 66% improved with antibiotics, however. We found no association between epi and SIBO workup or treatment response. Similarly, many patients got fecal fat testing as a marker for general malabsorption, with 45% having abnormal results. Those with epi were more likely to have abnormal fecal fat results. Bile acid sequestrants are often given for bile acid malabsorption diarrhea, and patients with epi were more likely to be treated, but not more likely to improve with that treatment. In conclusion, epi is common in post-bariatric patients with significant gastrointestinal symptoms. We found that patients were more likely to have epi if they were older, had a lower BMI, or a history of room-wide gastric bypass or biliopancreatic diversion with duodenal switch. This is potentially due to a combination of factors, including alteration in anatomy, loss of native neurohormonal signaling pathways, or decreased enzyme contact time with ingested food. Therefore, a high index of suspicion for epi is important in patients with GI complaints after bariatric surgery. The treatment threshold should be low, as current testing can be inaccurate, especially in those with mild to moderate disease. Other reversible causes of GI symptoms were common in these patients, but were not found to be associated with epi. Future studies should focus on identification of risk factors that are predictive of epi after bariatric surgery, evaluating the efficacy of PERT, and developing a reliable algorithm for the evaluation of post-bariatric surgery patients who present with significant GI complaints. I'd briefly like to thank my mentors, Dr. Leo and Dr. Ali, for their help with this study, as well as my co-authors who were instrumental in completing this work. Thank you, and I'll take any questions.